Welcome to this presentation on elbow joint effusion. We're going to talk about common etiology of elbow joint effusion, such as fracture, and usually that's in the patient population that falls on the outstretched hand or the Fossa mechanism of injury. You can also have other etiologies such as arthritis, and we'll talk about those very briefly. We're going to spend some time reviewing the anatomy and the radiology of the elbow. And it turns out that you can make fairly subtle and fairly sophisticated diagnoses based on a knowledge of pretty basic things like the 4 radiographic densities and the osseous anatomy around the elbow. One of the things that we're going to have to understand before we can approach the elbow are the fat pads around the elbow. So we're going to spend a lot of time talking about those fat pads. In fact, normally you don't see those fat pads very well, or you don't see them at all. And if you can see those fat pads, and I'll show you an example in just a little while, that gives you a clue that there might be something going on. And the underlying abnormality that lets you see those fat pads, or enables you to see those fat pads like a fracture, that abnormality may be very subtle, and it may be much easier to see those fat pads than it is to see the very subtle fracture. And we'll spend some time, very brief, talking about adult injuries versus pediatric injuries that may result in fat pad distension. So this is an elbow series, and there's a lateral view there on the left, and I've labeled the fat that you can see around that distal humerus. Now normally the fat is not that prominent. The reason that that fat is so prominent is that it is displaced anteriorly in the case of the anteriorly located fat, and posteriorly with respect to that posteriorly located fat. Normally you don't see the fat pads that well, and the reason that you see it very well in this case is that this person has a joint effusion because of a hemarthrosis, and that's pushing those fat pads out more anteriorly or posteriorly, depending on whether or not they're in the olecranon versus the coronoid fossa, and that enables you to recognize that there's an abnormality. On the other view, if you can identify the radial head, and we'll take a closer look at this in just a little while, you can see a very subtle fracture of the radial head. But I think that those fat pads are much easier to see, and that's why we concentrate on looking at those fat pads as a screen for abnormalities. So let's go ahead and talk about some of that anatomy and some of those normal structures. We'll start by reviewing the 4 radiographic densities. And remember, thankfully there's only 4 radiographic densities. And I've labeled the densities there on the anatomic specimen and on the radiograph. And you can see that we've labeled fat, which is sort of gray, soft tissue, which is also sort of gray, but a little more toward the whiter portion of the gray scale. Then we've got bone, which is also labeled, which is the densest structure in the body that occurs naturally. And then we've got air, which is the least dense structure. So you can see that fat there is sort of between air and soft tissue in terms of its density. Now normally you've got some fat around the elbow. You've got some fat that's hiding within the fossae around the elbow. So these are some images, some pictures, some photographs of the distal humerus, and I've labeled the olecranon fossa and the coronoid fossa on those anterior and posterior images of the elbow. The olecranon fossa, of course, contains a fat pad, and the coronoid fossa also contains a fat pad. And those fat pads are normally very difficult to see because they are within these very deep fossae. The other view there is a lateral view of the elbow, of the humerus, that rightmost view, and you can tell that it would be very difficult to see fat pads that are hidden within those deep fossae on a lateral view of the elbow because they're pushed deep into those fossae. Normally we don't see those fat pads. Now those fat pads may be pushed anteriorly with respect to the coronoid fossa, or posteriorly with respect to the olecranon fossa if you've got a joint effusion. So if you fall down, you break your, say, your radial head, and you bleed into your joint, you can push those fat pads anteriorly and posteriorly, making them a lot easier to see on a radiograph. And that may be our clue. In fact, a lot of times it's our only clue that there may be a fracture involving the elbow. These are some anatomic specimens, a transverse image on the left and a sagittal image on the right, that show these fat pads within the coronoid fossa and within the olecranon fossa. And you can see where you could anticipate that you might be able to normally see a little bit of the anterior fat pad in the relatively shallow coronoid fossa, and that would be true. But you very rarely, in fact you should never see a posterior fat pad normally in that very deep olecranon fossa. We talked about potential etiologies for elbow joint effusions that resulted in distension of those fat pads, making them visible on a radiograph. And the most common etiology in both children and adults is fractures. And the etiology usually is a fall on an outstretched hand. In adults, the bone that tends to get fractured is the radial head, whereas in children it's going to be a supracondylar fracture. And I've labeled both of those structures on these dried bone specimens. On the left is a normal lateral radiograph of the elbow, and on the right is that same case that we looked at just a little while ago. And you can see that normally you do not see fat pads around the elbow. You're just going to have soft tissue around that distal humerus. On the image on the right, you can see that you can recognize those fat pads very easily. It's the substance that is less dense than the surrounding soft tissue, but more dense than air. So those fat pads there are distended because you've bled into the joint in this person who has a hemarthrosis due to a fracture of the radial head. And I've circled the radial head fracture in that patient right here on the image on the right. And again, I think that's a much more subtle finding than the distended fat pads. And I will let you look for the fat pad distension here and see if you can detect the fracture best seen on the image on the right. This is a child. Obviously it's a child because there are open growth plates. And you can see a fat pad in a child also. I've circled it there. And this child has a supracondylar fracture. So in an adult who presents with a fall on an outstretched hand and a distended fat pad, the most likely etiology is going to be a radial head fracture. In a child with the same history, the most likely etiology is going to be a supracondylar fracture in the presence of a fat pad. Now, trauma is not the only potential cause of a distended fat pad, and I've illustrated a couple of other etiologies right here. The upper image there on the left is supposed to illustrate arthritis. So you could have somebody who's got a joint effusion because of a chronic arthritis such as rheumatoid arthritis. The image there on the left, more inferiorly, is supposed to remind me that if you had somebody, say an IV drug abuser, who had a history of a hot joint that very rapidly became inflamed and had distended fat pads and no history of trauma, you'd need to think of another etiology such as a septic joint. And the image on the right is supposed to remind me that you can see this in other potential problems. I've seen it a couple of times in patients who had leukemia, who had infiltration of the joint. But the most common etiology is going to be a fracture, and most of the people that present with distended fat pads are going to present with a history of a fall on an outstretched hand. So in an adult with a fat pad, you're going to be thinking about a radial head fracture, and in a child with an elbow joint effusion that manifests as distended fat pads, you would think about a supracondylar fracture. Thank you. This ends our discussion of elbow joint effusion.